All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound Case Series. Today, we're here with Dr. Deborah Pacik. Dr. Pacik's currently a sports medicine and interventional spine fellow at Mount Sinai in New York City. She completed her PM&R residency in the Bronx, and she'll be joining an orthopedic practice in New Hampshire near the coast, mountains, and her family starting, I think that's later this fall. She will also be staying on as adjunct faculty at Mount Sinai. Dr. Pacik is going to be presenting on the lateral femoral cutaneous nerve today, and I will turn it over to you to start sharing your screen.
Okay, terrific. Thank you. All right. So I should get started then?
Yep, looks great.
Okay, great. So I'm going to talk about the ultrasound of the lateral femoral cutaneous nerve and the anterior hip. I have no disclosures. And it takes a huge team and a wonderful team to get a fellow through fellowship. And my team has been amazing. The attendings are fantastic. My co-fellows are wonderful. So it's been a great year. And I just want to give my thanks to everyone who's helped me along the way. I also want to thank AMSSM and this ultrasound series, which is fantastic. The resources are amazing. These are just some of the hip videos. There's some other videos that are in that area also, but if anybody wants to go into more detail on some of these areas, you should definitely check these videos out. We're going to go over the anatomy of this area, differential diagnosis, a scanning protocol, and then we're going to look at a diagnostic report. So we'll start with our case. This is a 70-year-old woman. She has more than 1 year of right-sided lateral hip and thigh pins and needles. And she recently fell down and has had worsening back pain. She does have a medical history that's significant for hyperlipidemia, hypertension, and prediabetes. She did have both knees replaced, one recently and one a little bit farther away. And she's had no pain relief with a course of meloxicam and physical therapy. So on physical exam, she does have some pain on her low back. She's got really good range of motion in her lumbar and hip area. The most important part of this physical exam is that she's got decreased sensation to light touch over that anterolateral aspect of her right thigh, but her strength is intact symmetrically. So when somebody comes in with this kind of pain, the differential diagnosis is really, most commonly we're thinking about some kind of a lumbar radiculopathy, L3, L4, L5. Pain does go down that lateral aspect of the leg. It can go below the knee. On physical exam, you might have a positive straight leg raise, which would be leaning more towards L5. You might have a positive femoral nerve stretch test, which is positive for more of an upper lumbar radiculopathy. She could have a greater trochanteric pain syndrome. So she would report pain when she lays on that side at night. She might have tenderness to palpation in that area over the greater trochanter. She could have hip joint arthropathy or some kind of interarticular process, in which case she'd likely have a positive log roll, positive stent field. She might have a positive hip grind, likely decreased range of motion, especially if she has some arthritis. She could have a femoral nerve compression. That's some groin, more medial thigh pain. Also can come with some motor symptoms such as weakness in her quads. And then if the lateral femoral cutaneous nerve is compressed, that's really just sensory. It's just going to be pain, numbness, tingling on that anterolateral aspect of her thigh. Again, no motor symptoms, no weakness. This is just a sensory nerve. So we ordered some diagnostic tests. She did have electrodiagnostics, which was completely normal, except for no response on the nerve conduction study over the right lateral femoral cutaneous nerve, but that was normal on the left side. And we ordered an MRI and an X-ray. So this is an X-ray that we have an AP on the left, and we see some disc space narrowing, pronounced at L4 and L5. Maybe a little bit of sclerosis on that left SI joint, but remember, she's got right-sided pain. When we look at the lateral image, we do see that she's got a little bit of retrolisthesis on L5 from L4. It's grade 1, maybe grade 2. She does have an old pars fracture that we're seeing over here, but that was something that she's had for years. On MRI, she actually had a lot of pathology on that left side, but this was the most significant finding that was bilateral. So again, we see that retrolisthesis of L5. We see that there's some disc bulge. And then when we look on the right side at the axial view, we see that she's got facet hypertrophy and really pretty significant narrowing bilaterally of that foramen. So the lateral femoral cutaneous nerve of the path, it starts at L2 and L3. It travels over this through the psoas, over the iliacus, and then coming into the pelvis, just medial usually to the ASIS, under the inguinal ligament, and then down into that anterolateral thigh. This is one of the nice image of some of the sensory distribution, and another one on the right side here. So we were leaning towards Meralgia Paresthetica, given her symptoms with no motor involvement. There is a chance, given her pathology that we saw in imaging, that it was, an L4 radiculopathy, but that was, so it's definitely on our differential. But just to talk a little bit about Meralgia Paresthetica, it's also known as Bernhardt-Roth syndrome. And again, it's a sensory nerve. So it's really just that pain, numbness, paresthesias on the anterolateral thigh. It could radiate to the knee, but not below the knee, and it can radiate to the groin, although I think that's less common. And risk factors, primarily diabetes is a big risk factor. It's 5 or 6 times greater in the diabetic population than in the general population. But other risk factors that we see are really things that put pressure on that nerve. So a big belly, a tight belt, hip huggers. Somebody was just telling me about that. When hip huggers were in fashion, they saw a lot of this nerve problem. Sartorius can press on it when you're a dancer, and it can be damaged during surgery. And also if somebody has a mass or an infection in that area, such as a chronic appendicitis. So the AMSSM scanning protocol for the anterior hip is here. We are going to cover most of this, and then we're including the lateral cutaneous nerve of the thigh as part of this scan. So when I was thinking about a nice approach to how I was going to present this, I decided that I really wanted to focus on the bony landmarks. I think it's a good way to, we are often using this in ultrasound, bone is your friend. And so what we're going to do is we're going to start at the femur in short axis, and then we're going to scan proximal until we get to the lesser trochanter. We're going to do a scan of the hip joint, and we're going to have the neck in long axis, and then we're going to scan up to the AIIS and look at the surrounding tissues, and then up to the ASIS, and then scan down the ligament and look for the nerve that way. We used a bunch of different transducers. So it's actually a little bit of a challenge to do this area, because you have to switch between pretty deep structures at the thigh and hip joint, and then coming up to the ASIS, everything is very superficial. So it's either switching between transducers or really changing the depth and the focus. And for this exam, the patient is supine. So we start with the femur. We're starting again with the transducer in short axis. And this image goes pretty quickly, so I'm going to just repeat it a few times. So we're starting with that femur. It's nice and curved, and then it comes to be flattening out, and that's when we're getting to that lesser trochanter. And I think that it's really good to, one second, we're going ahead. I think it's good to keep that rectus femoris right in the middle of the screen, so that it's nice to keep, it's a good way to keep track of where you are in space and during the scan. And again, when we get to this lesser trochanter here, we're seeing the iliopsoas, we've got our rectus femoris, and on the lateral side, we've got tensor fasciolata. Medially, we've got sartorius, and then we've got up here, we've got our lateral femoral cutaneous nerve. And so we've scanned proximally. And so this is actually where I'm going to need people to have some spatial flexibility, because we've got medial on the video is over here and medial on this image here. But I like this image because of the layout of the muscles. It really is helpful as a guide when we're doing these scans. So again, we're coming up more proximally, and we're seeing the short axis of these, we're seeing these muscles in this view here. So we've got, superficially, we've got sartorius, and we see that right here. Medially, we've got our femoral head, we've got our acetabulum, iliopsoas right here. And then, so we've got sartorius, superficial, right below that is rectus femoris, and then sartorius, and then coming just lateral, we've got tensor fasciolata. So again, sartorius, tensor fasciolata. And this is just a really good image to keep in mind when we're doing this scan. And in this view, so now we've turned the transducer to long axis to the femoral neck. And so medially, we've got the acetabulum, we've got a femoral head and neck. And this is the view that we'll often use if we're doing injections, either at the femoral neck and head junction, or maybe a little bit more distal, if you're doing some regenerative medicine, depending on the person that you're working with. And so here we're looking at the anterior recess. We're trying to see if there's any effusion. We're looking at the joint capsule, seeing if there's any thickness. We can identify the labrum. And here we see the sartorius. Again, that sartorius is going to be on top. Medially is going to be the iliopsoas. Then we've got our rectus femoris, and we've got tensor fasciolata. So again, we can see that over here. We've got sartorius and rectus femoris, laterally tensor fasciolata, and medial iliopsoas. So we've scanned the femoral, the femur in short axis. We've gone up to lesser trochanter. We've scanned the hip joint. And now we're going to turn that transducer to short axis to look at the AIIS and the surrounding structures. One thing that's nice about this image is that this arrow is about the midpoint between the ASIS and symphysis pubis. And that's one of the landmarks you can use to look for the lateral femoral cutaneous nerve. In terms of if you're having a little trouble finding it. So what we've got is, I'm going to just stop here for a second. This is the AIIS here. And we've got the direct head of rectus femoris coming into view quite nicely. And then going up to a SIS, and we see how superficial that is. And it's really, I mean, it's a dynamic scan in so many ways, you know, changing that focal zone and changing the depth. So, and so what we've got here is ASIS. We've got our iliacus. Let's do that one more time, maybe. All right, we'll skip that. So, okay, so now we're on to, this is a static image of the AIIS in short axis. So, in the anatomy picture, what we've got is we've got our inguinal ligament, we've got our hip joint, we've got our AIIS here. And I really like this image because it shows the direct head and the indirect head going into that AIIS. And some of the other videos that are on this series really go into detail about how to visualize both the direct and indirect heads. And they're really excellent. I highly recommend it. And just to start, this is the lateral femoral cutaneous nerve coming down under here. So when we go to the ultrasound image, we've got our AIIS. We have the direct head of rectus femoris. This is lateral, this is medial. So we've got our sartorius, our tensor fasciolata, and down here we've got our iliopsoas. So I like this cross section because it again identifies some of the structures in there, where they are relative to one another. So again, we've got sartorius is that most superficial at this level. When we go lateral, we've got tensor fasciolata, and then medially, we've got the iliopsoas. So when we look at the ultrasound, we start at AIIS, scanning up to the ASIS. And then once we get up here, we've got sartorius over here, tensor fasciolata over here, our inguinal ligament on the top. So at this point, we've scanned the femur, we've done the hip joint, we've gone to the AIIS, we've gone to the ASIS, and then it's good to turn into long axis to the inguinal ligament and just taking a look at those structures. So what we've got here is, this is lateral, so we've got our ASIS right here, we've got our inguinal ligament coming down, we've got our iliacus right here, and then it's good to use this as a landmark, especially once you start scanning for that nerve. So we've scanned medially. We're going to scan medially now and just take a quick look at those femoral vessels here. So we've got lateral is on the right side of the screen. So we've got femoral nerve, femoral artery, femoral vein. You can compress that, make sure that that's the vein. Another option for this scan is once you get to, some people like to do the femoral vessels a little bit more earlier in the scan, but there's some variety of how you approach that part of the scan. All right, so now we're going to come to the lateral femoral cutaneous nerve. So again, it's a sensory nerve. It originates from L2 and L3. It comes through the psoas, through the abdomen, into the pelvis, coming a little bit more laterally. Coming over iliacus and then medial, usually medial to ASIS under the inguinal ligament and into that lateral thigh. This is a really nice image from a cadaver that shows the lateral femoral cutaneous nerve coming at an angle and then really making a pretty dramatic turn right at the ASIS. And this is the site where most compressions take place. And then coming down over sartorius and then into the lateral thigh. The study, this is from a study, this image on the right is from a study that used both cadavers and ultrasound to identify the variability in the path. And so what they found was that 80% of the nerves were within 2 centimeters of that medial border of the ASIS. 10% of the nerve traveled 2 to 4 centimeters medial to the medial border of the ASIS. 10% traveled lateral to the medial border of the ASIS. And this is just at the ASIS. There's also a lot of variability that's been shown in the literature that the nerve can come under the inguinal ligament, through the inguinal ligament, over the inguinal ligament, and at different paths through the sartorius. So I think having the ultrasound, if we're concerned that this is the diagnosis, having the ultrasound is really valuable in terms of correctly identifying that nerve. So this is a series of some still images just coming from above the inguinal ligament to below. And so what we've got here is we've got the nerve right here, and we see that it's traveling both lateral and superficial as we're scanning distal. We've got sartorius here, we've got the nerve here, and then right here we see that it's coming very superficial and much more lateral. When we want to really start focusing in on the nerve, it's good to start in long axis to the inguinal ligament. And depending on the variability on the path, you can either stay in this long axis to identify the nerve in short axis, or you might turn the transducer to have the inguinal ligament oblique. Just it kind of depends on the path of the nerve. So here we're scanning the nerve, we're scanning that with the ligament, the inguinal ligament in long axis. And what we see is the nerve right here coming up, 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 up. And again, we're scanning now just distal to the inguinal ligament. So again, a lot of the compression happens right at the inguinal ligament. But a lot of, if we're doing any interventions, we're often doing it just below the inguinal ligament. And so the pink is the lateral femoral cutaneous nerve. And this is scanning below, and we see here we've got sartorius. This is the lateral border of sartorius here, and we see this nerve coming in and out right here. And it travels in a fascial triangular pocket. So when we're looking for pathology, we want to identify it in short axis and long axis, and it's a little bit challenging sometimes doing this. So the scan on the left is the nerve in long axis, and we can see the alternating hyper and hypoechoic bands identifying it as a nerve. But also, just to confirm, for those of us who are suspicious, we're looking at the depth. So it's about 1 centimeter down. And so what we did on the right image was we scanned it in short axis and really paid attention to that depth of about 1 centimeter, and then spun it right on that nerve and went into long axis to make sure we were identifying the correct structure. Okay, so this, the diagnosis of Meralgia paresthetica is pretty uncommon. It's about 3.5 to 4.5 people per 10,000 person years. So it's not that common. I think some of it is just because we are very quick to diagnose a lumbar radiculopathy. And so it may be that there's more of this out in the population than we realize just because of not diagnosing it, but it's pretty uncommon. But even less common is getting a good image of the pathology on ultrasound. So if you have this image in your library, save it because it's gold. So this is a really great paper. It's a pictorial essay on identifying the lateral femoral cutaneous nerve with a lot of different abnormal views. So I highly recommend it if you're interested in this topic. This is a really wonderful paper. All right, so what they did was they have this nice image where you see that it's hypoechoic and it's quite enlarged. We see this in short axis, and then we see this in long axis. It's really thick and dark on this long axis view. And so in this study, they talked about how there are 2 other studies that have been shown that an area greater than, one paper says 5 millimeters squared, another paper says 9 millimeters squared, really is likely that Meralgia paresthetica is the pain generator or one of the pain generators. So on our patient, we identified the nerve. We've got it circled here. Here's sartorius. This is the lateral border. This is distal to the inguinal ligament. And her area was 22 millimeters squared, which is pretty significant. One of the papers that I looked at, their highest was 25 millimeters squared of the people they had studied. So it's pretty enlarged nerve. And because we were really suspicious that this was Meralgia paresthetica, and the intervention for this is much less invasive than doing transforaminal, we started with this, and we were going to sort of decide what we did next based on her results from this. So we did do the injection, and again, I've got the lateral femoral cutaneous nerve on the right here. We did the hydrodissection. She came back about a month later and she had 95% relief of her pain. So she had a really nice response to this, So it's good to, keep this in mind when people come in with that lateral thigh pain. It's good to have this diagnosis in mind, knowing that it also could be a lumbar radiculopathy or any of the other diagnoses that we discussed earlier. But having this in the differential, I think, is important for our patients. So the report was, we did this exam of the right anterior hip, the lateral femoral cutaneous nerve. We did it because she had this anterolateral thigh paresthesias. In general, the exam was pretty normal, except we did find that that lateral femoral cutaneous nerve was hypoechoic and enlarged at and just distal to the inguinal ligament. And she did have pain when we sonopalpated in that area. So the impression was compression of the lateral femoral cutaneous nerve at the inguinal ligament. These are my references, and that is the end.
All right. Thanks, Deborah. That was great. So, just a couple of thoughts I have on this. The diagnosis is one that sometimes seems simple, sometimes seems complex, and the the ultrasound evaluation in this particular area is it can be quite helpful, but it can also be challenging. And when we're looking at the inguinal ligament, I think it's important to remember that we're all taught that the inguinal ligament passes medial to the ASIS and deep to the inguinal ligament. But there's really a lot of different variations in how that nerve branches and how it traverses that region. And so from my standpoint, you sometimes will see it superficial to the ASIS, which is a little bit easier actually to see if you're looking for it there. And certainly, you can understand why someone would have compression there. You can see it, pass through the inguinal ligament, which is another, kind of tethering point, or oftentimes below the inguinal ligament. And quite frankly, the ones that go through and above, I think are actually a little bit easier to see than the ones that go deep, which oftentimes it's a little bit challenging to get a good image of the nerve until you get distal to the inguinal ligament. And then also just remember that when you're looking at like measurements and cross-sectional area, this nerve can actually branch really high, and so you can have branches that are separated from each other by the time you get to the inguinal ligament. And so when you're just taking an absolute measurement, you may see a focal nerve enlargement without an absolute, increase in caliber of the nerve itself, because you have multiple branches at that point. And then, I've even seen where people have reported the nerve can travel through a bone tunnel through the iliac bone and not through the soft tissue. I've not seen that on ultrasound. Doug, I don't know if you maybe have, you'd be the one that would probably have 18 cases of that, but just remembering that anatomy can be really variable, and that can really affect how you approach this. And then, when we're looking at that anterior hip protocol, I think the hip is one area where I really lean heavily on heading both medial and lateral from the anterior hip as I'm kind of going through my differential diagnosis. So looking at that anterior facet glute, I know that's something that that I didn't do consistently until Doug pointed out a while back, and I've seen a couple of patients where I would have missed pathology without heading further lateral. And then same thing, sometimes heading in like towards the adductors and pectineus and rectus abdominis kind of complex can occasionally provide some additional information. So just a reminder to make sure that as we're going through these kind of complete protocols, making sure that we're hitting the required areas, but also adding in the clinically relevant areas in the other protocols at that time as well. I think that's all I have. Doug or Ryan, I don't know if you guys have any comments.
Yeah, nice job, Deborah. I just really want to echo what Brennan said, and I think the key is to understand the heterogeneity of the nerve. And by understanding that heterogeneity, you get a better sense of how or why you might be entrapped and how you might approach it. And as Brennan said, it can be really difficult and challenging. One of the tricks I do is I find it sometimes easier, as one of your first ultrasound images showed, is to find a branch of the nerve in those little fibroosseous tunnels that happen in the subcutaneous tissue superficial to the sartorius. And I find that pretty easy and then I very carefully will follow that branch until it coalesce somewhere around the ASIS. And so that's a trick that I do if I'm if I'm not seeing that nerve right away, or if I'm confirming that truly is the nerve, is I'll scan a little bit distal, find one of those prominent branches, and then carefully scan it back. And as Brennan said, I've seen a few of these sitting on top of the ASIS, and the ASIS is very irregular. It has a lot of bony irregularities, and it's easy to see why the patient might be having Meralgia paresthetica. I'm curious, both Deborah as well as Brennan and Ryan, what is your preferred way of hydrodissecting these?
Yeah, so I think it depends a little bit on where the problem is. I actually, a lot of the lateral cutaneous nerve injuries I see our like second opinion. We have a complex hip scope practice here, and so our surgeons see a lot of second opinion hip scopes for ongoing pain. And so I see a lot of iatrogenic injuries, I would say maybe relatively speaking, to this nerve from hip scopes. And so for those, I typically, it's when it's getting a little bit deeper, I typically go lateral to medial. Up at the inguinal ligament, it depends a little bit on where the nerve is. If it's sitting deep, I still typically go lateral to medial. If it's superficial or if it's going through the ligament, sometimes I'll try and go in plane with the nerve from distal to proximal, but I would say more often than not lateral to medial.
Ryan, Deborah, is that what you usually do, is go lateral to medial, short axis in plane?
Yes, and usually it's trying to get above where it's branching, sort of at the area where there is that the site of the compression or before it starts branching, so you can really make sure you get all those nerve branches.
Yeah, I mean, that's, that's the my preferred way as well. It does get challenging at times if that nerve is hugging very tightly that medial border of the ASIS, and it can be really tough to get that needle in between, because it's nice to get that needle in between the ASIS and the nerve itself, and then push it away and try to free it up. But if it splits or if it's really hugging tightly under the inguinal ligament, it can be very challenging.
Yeah, definitely can. And the other thing, sorry, I didn't mention is, one of the things you pointed out early on, Deborah, was the need for, I would say the hip is a little bit unique in the need for multiple different transducers for almost every scan. And so, most of the, the newer ultrasound machines, the linear transducers, kind of the lower frequency linear transducers, are typically adequate for most of the hip diagnostic. Even in people who are quite a bit bigger, you can still get pretty good images of deep structures with a lower frequency linear transducer, occasionally needing to go to the curvilinear transducer. But I would say, I've switched my personal practice to a lot more of my diagnostic being with my low frequency linear and less with the curvilinear, and really relying on the curvilinear only for, really deep injections. And so, as we're looking at these superficial structures, I'll even times, you can even use your really high frequency linear transducers for this particular nerve. Just because it's so superficial, you can get really great high resolution imaging for most people with that. And so just, taking the time to switch transducers instead of using what's convenient is really helpful as well. All right, does anyone have any other comments or questions? All right, perfect. So we will be back in a couple more weeks on June 23rd. That'll be the last of our fellow series for the year. It'll be with Dr. Ramirez, and we'll be talking about tarsal tunnel syndrome. Thanks, everyone. Have a great day and good weekend.
Thank you.